is repeat x-rays because they move, okay? So our main thing with radiation protection is we want to minimize repeats. And our second important thing is we need to always shield, okay? We shield adults too, but in children, we're just going to make sure we are always shielding, just like we do with the adults, using the correctly sized pediatric shields, okay? You should have smaller shields used for children, okay? So these ones on the left here are male and female gonadal shields. These horseshoe-shaped ones, U-shaped ones, are female gonadal shields. These more triangular-shaped ones are male gonadal shields. And what these honestly are, these are cut from a lead mat. Those lead mats we use in the x-ray room, these are just cut from that. But these work as gonadal shields, contact shields to lay on the patient. In something like a chest x-ray like this, she's been given a pediatric waist apron, right? A waist shield. Where we have adult ones, we'll have pediatric ones as well. Parent protection. As we said, but to recap, parents wear lead aprons when they're in the x-ray room. They wear the full apron that goes over the shoulders. If they're assisting with the procedure at all, holding the child, they need to wear leaded gloves. And your parent should be, you really shouldn't want to use the parent. You only use the parent if you need to, okay? Your first choice is a parent or guardian, though. If somebody needs to hold a child still, your first choice is a parent or guardian. Your second choice is other office staff, okay? So like medical assistants, receptionists, the doctor can help you, okay? You'll never use a student. Students are never allowed to hold during procedures. And the technologist, the radiation worker, which is sort of contrary to what you would think, they're your last choice, okay? The x-ray techs know how to hold and support in position, but we're the last choice because guess what? We're the ones spending the most time around x-rays, right? So we're going to try to minimize our extra exposure to the x-ray beam. Okay. So yeah, parent is first choice, office staff is second, students are never a good option, and technologists are your last choice. Okay. So what we're going to do now is we're going to get kind of specific and technical here. We're going to start talking about actual exam information for children, so things to think about for exams, okay? So those of you who have never heard anything about positioning, this is all new to you. Those of you who have taken positioning with me, these are some modifications to positioning for children. Okay, so positioning for chest and skeletal system. One of the most common studies done on the very, very young children, newborn and infant, it's going to be a chest x-ray. Abdomen x-ray is probably your second most common. But assuming we don't do abdomens, chest is going to be the one that you ought to be familiar with. There is our TAM-M board, which is the immobilization board. Underneath it, it has a space for the cassette to be placed, and it has supports for the arms, for the waist, and for the legs. Central ray. The level of the central ray is the nipple line on young children. That may be a little bit different than it is for adults. In adults, we use something like 4 to 5 inches below the jugular notch or 7 to 8 inches below the vertebra prominens, right, for chest x-rays. For the recumbent child or infant, centered to mid-thorax or nipple line. No rotation. Rotation means we don't want them rolled to the right or to the left. Always collimate to the outer margins of the chest. What's your guys' rule of thumb for collimation? Like how much of a collimated field outside of the body part? 2 inches? An inch? So I usually say an inch, and there's a technical reason for it. Your light field that you see can be offset from the primary beam, the actual radiation field, by as much as 7/10 of an inch, and still be within the tolerances. Okay, that means if you leave an inch of light field on either side, if your beam was offset by 7/10 of an inch, you would not miss any of the body part. Make sense? Okay, so if you collimate more than an inch out, you're almost giving too much, okay? Having too much of light, too much extra light field. But if you give an inch, that's reasonable. That allows for offset between the actual light field that you see and what is the actual radiation field, because they don't accurately match up. Collimate to the outer chest margins. That's recumbent. Erect PA in the pigostat. Use the pigostat. We talked about how to use that. Central ray is placed perpendicular to the mid-thorax or nipple line. No rotation. That means in the PA, their mid-sagittal plane is perpendicular to the receptor. PA chest x-ray. In the lateral, their mid-sagittal plane is parallel to the receptor. Okay? So again, you're always trying to think about what is the relationship of one plane of the body compared to the beam or the image receptor. Okay? And if for example, if the mid-sagittal plane in the PA down below here is perpendicular to the image receptor, it's parallel to the primary beam. So what is the relationship between those structures? When you evaluate a PA or AP child's chest x-ray, you're trying to look for no rotation. Those of you who have shot chest x-rays on adults, what do you look for to know if they're rotated? That's not going to be my main thing. The reason for that is the heart is larger on the left than the right, so it's not symmetrical at all. Okay. What bony anatomy might you look for on a chest x-ray? That's for counting for inspiration, for counting if they took a big enough breath.
The spine.
What about the spine?
The spine dots, maybe, like...
So the spine is important. Where is the spine on the body? In the posterior, but correctly, RV, it's centered, right? The spine runs along the mid-sagittal plane of the body. It's in the middle, okay? Okay. So there's the spine on the mid-sagittal plane, right? And anteriorly on the body, you have the clavicles, okay? The clavicles connect to this bone called the sternum. The top of the sternum is called the manubrium, but importantly, the clavicles connect to the sternum at a joint called the sternoclavicular joint, okay? When you look at the chest x-ray, you can see, I know it's got to tune your eyes in, but you can see the clavicles, and you can see the sternoclavicular joints here and here. I can also see the spine. There's the spine right in the center, okay? So what I'm looking for is where are the sternoclavicular joints in relationship to spine in the midline of the body, okay? If they're not rotated, then the distance from the spine to this sternoclavicular joint and the distance from the spine to this sternoclavicular joint are going to be the same, right? And as you can see, if I'm looking towards you, if I rotate, right, this sternoclavicular joint moves that way, right? This one moves away from it as well, away from the midline. So one will get closer to the midline of the body, the other will get further from the midline of the body. If they're rotated this way. If they're rotated the other direction, the opposite is true, okay? So when you look for rotation, you can look for a lot of things. You can look for symmetry of the lungs, you can look for where the heart's located in the chest, but I like to rely on bony anatomy, okay? And we know the spine is centered in the back, as long as they don't have like severe scoliosis. We know the spine is centered, and we know the sternoclavicular joints sit to either side on the chest x-ray of those vertebrae, okay? And so you can look at the relationship between sternoclavicular joints and vertebrae and tell if the patient's been rotated or not, okay? So that's rotation. The second thing we're going to evaluate for on a chest x-ray is inspiration. Okay? When we breathe in, our lungs expand downward, they expand laterally, and they expand anteriorly. But importantly on the chest x-ray, you can see the up and down expansion, right? The vertical expansion of the lung field. Okay? So when you look at the chest x-ray, you'll notice that you can see ribs. Okay? Now, to you, to your eye, some of the ribs go out that way, come from the midline and angle downward. But then you also see some ribs coming like this from the outside and angling downward towards the body. So you have some going like that and some going like that. Okay? What you're actually seeing is the posterior ribs attaching in the back, they come from the spine and they angle downward. Okay? But that same rib, when it wraps around to the front, begins to angle downward facing towards the midline of the body. Okay? So what you're seeing here is an anterior rib. Follow it up. And now there's the posterior rib. This is the, let's count it. 1, 2, 3, 4. We'll count from this one. This is 5. So this is the 5th posterior rib. That's the 5th posterior rib. Wrap it around. And there's the 5th anterior rib. It's the same rib, just part of it's in the front of the body and part of it's in the back of the body because the ribs have to wrap around the thorax. Okay? When you evaluate chest x-rays, adults, children, doesn't matter what age, you count the posterior ribs. Okay? So I'm not going to count from these anterior ribs. They're too hard to count. Okay? The posterior ribs attach to the spine. Now, they're kind of hard to see. You've got to tune your eyes into them. This is the first rib here. Okay? On this skeleton, it's here. Okay? Here and there. That's the first rib. That first rib is attached to thoracic vertebra number 1. Okay? The first rib here. The second rib superimposed on it, okay? Because the first rib sits so close to the second rib and it angles downward, the first and second ribs almost always appear superimposed on top of each other, okay? So there's posterior rib 1, posterior rib 2, and just below that, posterior rib 3, okay? The first 3 ribs are often above the clavicle, okay? The 4th rib here almost always hides behind the clavicle. It is superimposed by the clavicle, okay? 1, 2, 3 above the clavicle, 4 behind the clavicle, 5 below the clavicle. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And now I can't see any more ribs, okay? So I would say that I have 10 ribs shown above the diaphragm, okay? The diaphragm is the large flat muscle separating the abdomen from the lungs. Why can't I see any of this down here? It's all white. Why can't I see it? Yeah, it's fluid filled. It's like blood-filled, fluid-filled organs, right? And the way we set up our projection is, we set up the there's a ghost in this room. We set up the projection to image the lungs, right? We didn't create an X-ray beam for this projection that was able to penetrate the abdomen. We made it able to penetrate the lungs. So the lungs appear black. That's all this black that you're seeing, okay? So when you shoot a chest X-ray of someone of any age range, male, female, young, old, whatever, you need to check for rotation. You do that by looking at the sternoclavicular joints in relationship to the spine. Then you count how many posterior ribs you can see above the diaphragm. Okay? You want a minimum of 8 posterior ribs above the diaphragm. Ideally, you have 9 or 10. Okay? If you're asked on a test, what is the minimum? It's 8. If you're asked on a test, what is the ideal? It's 9 or 10. Okay?
Unless it says in good health.
Yeah, in good health. That was I'm remembering that one when I say that. But so those are two important things: rotation, inspiration. Okay. My third important thing for chest X-rays is called penetration. Again, you notice the abdomen is white. That's indicating that the X-ray beam wasn't able to penetrate the abdomen. What you need, though, for a chest X-ray is you need the X-ray to have penetrated the chest. Okay. And in the chest, you have one big muscle filled with blood, and that's your heart. Okay? So for penetration, I need to see the black lung field, which is as black as the background, and I need to see the spine through the heart. Okay? If I can see the vertebrae of the spine through the heart, and a black lung field with black background, I have enough penetration. I remember this as RIP, rotation, inspiration, penetration. Okay? If you can remember those three things, you'll be able to evaluate chest X-rays very quickly and easily and have minimal difficulty in doing so. Now that's only for the PA chest X-ray. The lateral we use RIP as well, but we'll use it in sort of a different context, and I'll explain in a moment. So on lateral, you may also use immobilization aids. Sandbags can help, tape can help, or the immobilization board can help. You'll notice on lateral, our central ray is placed on the mid-coronal plane at the nipple line, which is the same as it is for the PA or AP. No rotation. I'll show you how no rotation is evidenced in a moment. In the pigastat, central ray is placed in the same spot. No rotation, as in their mid-sagittal plane is parallel to the receptor. What else could I say? I could say mid-sagittal plane parallel to the receptor, or I could say, what other plane of the body could I use? If their mid-sagittal plane is parallel to the receptor, what's their coronal plane doing? Perpendicular to the receptor, right? So I can say coronal plane perpendicular, or I can say mid-sagittal plane parallel. Both of those things mean the exact same thing. So when we look at the pediatric lateral chest X-ray, it's the same setup as evaluating an adult's chest X-ray, which is why I'm teaching you the same things as evaluating adult chest X-rays. No rotation, okay? No rotation is evidenced. I'm not going to go stand up and, well, yeah, I am. No rotation is evidenced by the ribs superimposing. That's a posterior rib, that's a posterior rib, that is, okay? And they need to stack on top of each other, okay? When you view the chest from the side, the ribs should, one side, the right ribs, should not be further back or further forward than the left ribs. If they are rotated in relationship to the image receptor, one set of ribs will look further back than the other, okay? And you can tell which side it is. Now, when we do a lateral chest, do we do a left lateral or a right lateral? Left lateral, good. So you guys are the board. You're the image receptor, okay? I'm the X-ray tube over here. So they're in left lateral like this, okay? What do we know about object to image distance? What does it do to magnification? What does? Yeah, the further something is from the image receptor, the larger it appears, right? Which set of ribs are closer to you, the left or the right?
The right.
They're in left lateral, so their left ribs are closer to you, right? This facing, the patient doesn't have a head, they'd be facing that way, right? This is our left side closest to you now, right? So which side's furthest from you, right or left? Right side. So are the right ribs going to look bigger than the left ribs?
Yes.
Yeah, they're further away from the image receptor, okay? So here's the deal. If you evaluate the lateral and you notice that one set of ribs looks like it's rotated back in relationship to the other set, if they appear larger, then you can tell which side they're rotated from, right? So if the right ribs, if you're looking at this x-ray, and you're looking at ribs projected backward, right, back this way, and they are larger than the other set, they appear physically larger than the other set, you know that their right side was rotated backward. And you can go in and fix it by rotating them back into position, rotating the right side further forward. Okay? If they rotate this way, okay, and now you see a set of ribs projected backward, but they're the smaller looking ribs, okay, you know that their left shoulder was back and their right shoulder was forward, and you can correct for that. Okay? So there's always a way to evaluate and correct your image. You just have to get smart about it, right? You have to understand the technical things such as OID, and something further from a receptor will look larger, okay? And you can say the larger ones, if they're further back, then the right shoulder was back. The smaller ones are further back, then the right shoulder was forward, or other ways to say it, left shoulder was back. But again, the point is, there's always a way to evaluate it. You're never left guessing, okay? There's always clues given to you. This is why we say that the image, that the remnant beam carries a signal, carries an image signal, right? Carries information. There's information here. You just got to get good at getting the information out of it, right? And you did your best on the lateral when the ribs superimpose on each other, when they look stacked right on top of each other, okay? Which is what's shown in this image here. That's rotation on the lateral. Inspiration is sort of the same thing. You just look at the PA and the lateral and compare the relative size of the chest lung field. And for penetration, I need to be able to see some bones projected behind the heart. So I look at the heart, shadow of the heart, and I see that there are ribs projected through the shadow of the heart. And I know I have enough penetration. I know my beam energy is high enough. Okay. Upper limbs. Upper limbs, one of the best ways to do things is to use immobilization techniques with sandbags, tape, or a parental or guardian assistance. Again, sandbags are your friend there. Lower limbs. And often requested, and especially on pediatrics, is like, in an adult, you would shoot like an ankle, a tibia fibula, a knee, or a femur, or something like that, right? Often in very young children, because they don't, so an adult could tell you it hurts right here, right? A very young child, before they can talk, will not be able to tell you that, okay? They may be able to give you some indication, but often physicians are sort of left in the dark about exactly where they're hurting, right? So often, especially in the lower extremities, you get a kid whose parents brought them in, they're carrying them, and the kid won't put any weight on their body, and the parent has no idea what happened, okay? They fell off the trampoline, and we don't know, all right? They don't know where they're hurting. They'll often ask you to radiograph the entire lower limb, in which case you just try to get as much as you can on a single image, okay? So that's really common, radiographing an entire lower limb or an entire upper limb. You call it a right or left leg or a right or left arm, right? Rather than being specific to like wrist, forearm, elbow, humerus, or ankle, tib, fib, knee, femur, you'll just be the whole thing, okay? So that's common enough. So expect to do things a little differently with children, such as x-raying the entire limb, which you wouldn't do in an adult because they don't fit. You may also immobilize, again, with tape or parental assistance. I prefer tape, okay? Tape's a great reminder, okay? It doesn't hurt, right? And parents are just not good at holding kids still, okay? I'm a dad and I'm a radiographer and I'm pretty good at holding kids still, but when it's my daughter, I'm just not. You don't want to hurt them, right? But if they're not your kid, you're okay holding them. So they're not going to get hurt. I promise you. You'll experience this if you ever have children. I took my daughter in for vaccinations recently, and I was not able to completely immobilize her when it's not my child. So it's a real thing. So even if their parents work in the medical field, that they're just not good at holding kids still. But let them help if they can. In other cases, we like tape or some other immobilization aid. And yeah, if you're x-raying an entire limb, center to the mid-limb, okay? There is no special central ray placement. It's just in the middle of the body part. Bilateral lower limbs might be an option. Physicians will often request what are called comparison studies, okay? Now, if you know they're going to get the comparison study before you go to shoot the original injured side, you can ask, or they can request that you shoot it bilaterally, okay? Bilaterally means to shoot both objects at the same time, okay? You mentioned earlier, Parrish, bilateral knees that you shot at the orthopedic office. Huh?
I said all day long.
Yeah, all day long, standing bilateral knees. And you know, in this case, it's just a bilateral of the lower limb. Okay, this position here, if you had to guess what that's called, and it's not called lateral, what would you call it? Frog legs, right? It looks like frog legs, right? So we call it a frog leg position, and you'll notice there's a sandbag being used down here to weight down the feet. There's shielding placed up higher. The gonads of this child are not necessarily shielded in this case because placing the gonad shield may interfere with visible anatomy, visualizing the appropriate anatomy, and it may require a repeat x-ray. And a repeat x-ray is worse than just not shielding the gonads on the first one, okay? So in some cases, gonad shielding is not appropriate, right? You just have to learn when and where it's appropriate. That is the bulk of learning radiation safety over these next few months, is learning when and where it's appropriate to shield people. But good, you have that bilateral lower limbs. This is not the same study because this one has shielding placed on the gonads, but this is an example of bilateral lower limbs showing the entirety of the lower extremity, AP, and showing the entirety of the lower extremity in lateral. We got very close to the edge here on this right leg, right? But either that image was cropped as an image or that was repeated potentially. Good. So what you want to do is make sure that both body parts are in the same position, though. So you wouldn't want like one leg with the foot rotated out and the other leg with the foot straight up. You want them both kept in the same position. AP and lateral of the foot on the little munchkin with little chubby baby toes. Okay. Unilateral study. Okay. And in this case, they're using tape, right? So shielding, you can see shielding present here, shielding for the gonads. But centering to midfoot, the positioning here is the same as for adults. It doesn't change, okay? Central ray to midfoot, you're still angling the central ray so that it's perpendicular to the dorsum of the foot. And then you do your lateral, central ray to midfoot. So that doesn't change. If you can do a foot study on an adult, you can do it on an infant. What's missing? What would normally be included on a normal foot series? What's missing here? Oblique, right? Why no oblique?
Because the bones are
Yeah.
fully there.
Yeah,
They're not like
they haven't ossified yet, right? They don't have all the bones that the adults have, right? And so there's no need to do the oblique because we do the oblique for viewing joint spaces, and their joint spaces are all very well spread apart, right? So we don't need the oblique. So obliques are often not included. Pelvis and hips. Pelvis and hips are often done bilaterally. Again, I said that physicians do. I didn't really mention why they get bilateral studies or comparison studies. And the reason is because children, when they fracture bones, they don't fracture bones like we do. I told you adults do a really good job of fracturing bones, right? Children, when they fracture bones, often have growth plate fractures called Salter-Harris fractures. There's 5 different types. Or they have plastic or green stick fractures. It takes a significant mechanism to completely fracture a child's bone because they're so bendy. So often we do bilateral studies, comparison studies, to detect minor differences in how one side appears versus the other, okay? And so expect to do more bilateral or comparison studies on children than you would for the adults because adults' fractures are usually more obvious. Determine the ability to use gonad shielding when you do pelvis and hips. There's been a new study, a new paper produced, not even that long ago, a couple of years ago by the National Council on Radiation Protection and Measurements, and they basically are recommending against the use of gonad shielding in pelvic x-rays and hip x-rays. I'd be happy to share the study with you guys or send a link for it to you guys, but officially the ARRT has not adopted that material yet, and the state of California has not adopted that material yet. So we still shield when it's appropriate, but there's strong recommendations to stop shielding people's gonads on pelvic and hip x-rays for a lot of different reasons, but I'll give you just one right now. We're not accurate in positioning the shields. Okay, where the ovaries are at in females differs widely, right? They did a study of a couple hundred females and ultrasounded their ovaries, and they plotted them on a graph, and you should see the spread of where ovaries hang out in females from one to the next, and the shield shown here, the ovaries are like all over the place, okay? That's one issue. The second issue is shields in pelvic and hip x-rays are likely to cover anatomy that you need to see, which will lead you to have to repeat the x-ray, okay? So we're starting to recommend against that. There are strong scientific recommendations to stop doing it, but at this time we're still acting as if we should be shielding, and we do when it's appropriate. So we're asking you to determine the use of gonad shielding when it's appropriate. Shooting things like a lateral of the hips and pelvis, specifically the hips in this case, the frog leg position, you want to try to make sure there's no obvious fractures, okay? When you move body parts, move them slowly, move them deliberately, but slowly, and try to focus on what you're moving. Try to focus in on the joint that you're moving. Pay attention to where you feel like resistance to movement, right? Patient resistance or actual like bony resistance to movement. Pay attention to the feelings of crepitus, which are when bone edges kind of rub together on broken bones. Be mindful of what you're doing when you're positioning any age range, but children especially. And so try in all cases to look at the AP first, rule out seeing an obvious fracture, and then position for the frog leg. Okay. In fact, the rest of this talks about